It's my pleasure to introduce the second keynote speaker of our conference, Ron Summers. Ron is a radiologist and he works at the NIH Clinical Center in Bethesda. He has been working there for a very long time. And basically as long as I go to conferences on computer-aided detection and computer-aided diagnosis, Ron was always there. He used to always give talks about colonoscopy, polyp detection. But I think about 10 years or a bit more ago, he started to expand into other areas. And he actually did something very interesting. He published a paper in 2003 in Radiology with the title Roadmaps for Advancement of Radiological Computer-Aided Detection in the 21st Century. So he really published his roadmap, and in this article, which I really recommend, he really explains what we should do and basically make computer-aided detection systems for all these other things that radiologists sometimes see in medical images. We should not focus only on these few hot topics, but there are so many things that a radiologist could pick up. And what I found interesting is that in the years after that, he started to implement this agenda. So he first published it, and then he started to implement it, like you should do with clinical trials. And at every conference, Ron would be there, and he would present a new computer-aided detection system, usually for a disease that I had never heard of. But yeah, as he is a radiologist, there are a lot of diseases out there. And he really started to show all these applications one by one. And I think a few years ago, when deep learning became popular, his lab was really one of the first to massively invest in that, and he has co-authored a lot of publications on applications of deep learning to medical image analysis. He also has released a lot of data sets recently, and he really has opinions about that, and I know that he will talk about that in his keynote as well. And we'll discuss that also further on Friday in the panel discussion that he will also join. So Ron, the floor is yours.
Thank you so much, Bram, for that wonderful introduction. I'm really touched that you read that paper in radiology. So, and thank you all for returning from lunch. Okay, so here are my disclosures. The work that I'm going to present today was done nearly in its entirety at the NIH Clinical Center just outside Washington, D.C. This is a hospital that's actually the largest hospital in the world devoted entirely to clinical research. And all the patients who are taken care of at this hospital are taken care of for free. They don't pay a thing to be studied in clinical trials at this hospital. Very unique resource for the world. I'm going to have a very brief introduction. I know most of you are experts on deep learning, so I won't go into that in really much detail. But then I'll get into a wide-ranging overview of many different radiology imaging applications. And my hope is that at the end of this presentation, you will have a sense of the number of different problems that radiologists and clinicians face in using radiology images, and we'll get a sense of how vast the landscape is of problems that could potentially be tackled if we had the data to be able to tackle them. And in the last part, I'll talk about data mining radiology reports and images, and this complements the second theme in that it shows how to get huge radiology data sets and have them be annotated using weak supervision using the radiology reports. So every radiology study is interpreted by a radiologist. That radiologist will produce a written report, and what we've been trying to do is use those written reports as weak annotations so that somebody else doesn't have to sit down and laboriously annotate all the images. The idea is that ultimately we could have hundreds of millions of radiology studies in a database, all weakly annotated using some sort of natural language processing on the reports. So that'll be the final theme that I'll touch on. In this presentation, I'm going to talk about a variety of different types of radiology. Towards the end of the talk, I'll get into chest radiographs, the middle set of images here are MRI scans. I'll talk very briefly about MRI. I'll spend most of the time talking about CT scans like this chest CT here, and I won't talk much about PET scans like this PET CT on the right, but that is another area that's of great interest in radiology image analysis and where we've done some work on tumor growth modeling. I think one of the other presentations at this conference will be covering tumor growth modeling. So before my lab got invested in deep learning technology, we did the usual feature-based computer-aided diagnosis that was in vogue prior to that era beginning, and I'd say that was up to about 2012 or so, or maybe a little later, 2015. And the type of computer-aided detection that we were doing in radiology includes, for example, this is virtual colonoscopy polyp detection. This is a CT scan of the abdomen, and the structure in blue is a 1 centimeter polyp. That's a precancerous growth that, if not detected and removed, can lead to colon cancer. This is an example of vertebral level parcellation or identification of the different levels in the spine. This is very useful as a coordinate system for identifying abnormalities, and I believe there's a talk on this topic later in the conference. This is an example of fully automated bone mineral densitometry. This white structure on the CT scan is the spine, and particularly in older patients, they can suffer from decreased bone mineral density, known as osteoporosis, and there are drug treatments to prevent osteoporosis and the consequences of that, which are fractures of the spine. That's one of the reasons why people get shorter as they get older, because the spine fractures and the vertebral bodies get shorter in height and the overall patient height diminishes. This is an example of a detector of a cancer deposit within the spinal canal. The spinal cord goes here, and if these cancer deposits are not detected early, they can lead to paralysis or loss of bodily functions. And this turns out to be one common early manifestation of cancer spread, and it's also a very common type of cancer that is missed because radiologists tend not to focus on the spinal canal very much. This is an example of a small bowel detector for CT scanning, and what was unique about that project was that we used the blood vessels that feed the small bowel, that's all those yellow spindly structures you see in the image, to identify what's called the mesenteric side of the small bowel, and then we use standard region growing techniques to identify the other side of the bowel, the anti-mesenteric side. This is, as far as I know, one of the few methods for small bowel segmentation, and that's a very important problem for automating abdominal and pelvic CT and MRI image analysis because the small bowel is about 22 feet long and consequently occupies a substantial fraction of the voxels in the abdomen and pelvis. It's very useful to be able to identify that. This image shows automated organ detection in the abdomen. The different colors are the liver, the spleen, the kidneys, the aorta, the adrenal gland. We heard about that in one of the talks this morning, and there are some talks and posters later in this conference that focus on that. I believe that this is a very important problem that could lead to automated volumetry for radiology studies on a routine basis, and I think deserves more attention. This is an example of an automated kidney lesion detection. This is the kidney here, this sort of grayish structure, and these red things are cancers in a patient with hereditary kidney cancer. And finally, this is a lymph node in the abdomen. Lymph nodes are very important in cancer patients because cancer tends to spread first to lymph nodes, and when trying to figure out whether and how to treat a cancer patient, we usually will look for enlarged lymph nodes, and so it's a very common task that radiologists engage in. So now that everything has changed with deep learning and convolutional neural networks, we've started to invest heavily in different problems that have proven intractable to some extent using the conventional feature-based methods. Here are some examples. I'll get into these in more detail later in the talk. At the top left is a colonic or large intestine inflammation detector. This type of inflammation occurs in patients receiving immunotherapy, which is a type of cancer treatment. This is abdominal atherosclerosis plaque detection. Most atherosclerotic plaque detection is done in the arteries that feed the heart muscle, but we believe there will be some unique applications in the abdomen and pelvis for that task. This is an example of a prostate lesion biopsy recommendation system. In this case, this is an MRI of the prostate, and here's the cancer, this gray area. You can see the prostate is a very heterogeneous structure. It's sometimes difficult to see these cancers, and this is an example of a deep learning-based system, which I'll talk about in more detail a little later. Okay, so now that we've entered the deep learning era and we've heard from the speakers this morning that handcrafted features are less important and that large annotated data sets are more important, what's happening is that people like you are pouring into the field, greatly accelerating the pace of progress. And this is something that I think the field really needed. It needed more ideas. It needed a quicker turnaround time at developing these systems. To give you some perspective, it would frequently take us a year to put together one of these systems from the beginning, and then in order to get a 5% sensitivity improvement, we would have to work another year. And to contrast that, we took one of our feature-based systems and applied deep learning to it and attained double-digit percentage increases in sensitivity simply by layering deep learning on top of an existing system. So clearly, I know you've all bought into the idea, but I was convinced at an early stage that this was the way to go. So again, without going into too much detail, by getting rid of this feature calculation, this former feature calculation box in our development pipeline, we vastly accelerated how quickly we could develop these systems and iteratively improve them. In radiology, the interest in deep learning is taking off in an exponential way. This is a histogram showing the number of papers in PubMed. The orange bars are all papers on deep learning, and the gray bars are all papers using deep learning in radiology. This is through the end of 2017, and you can see we're starting to get the same exponential increase that we have in medicine as a whole. So one of the things to keep in mind is that despite the great promise of deep learning and machine learning in developing these automated systems, we still don't have too many systems that can perform at the level of a trained physician, be they a radiologist, a cardiologist, or whatever. This is an example of a diabetic retinopathy system that I suspect many of you are familiar with. This was published in JAMA in 2016, and this system was one of the first that showed physician-level performance for the task of detecting diabetic changes in the back of the eye. Another such method that performed comparably to trained physicians was this paper published in Nature in 2017. This is one in which a deep learning system determined what type of cancer a skin lesion was and also compared whether it was a benign or malignant lesion. And this also had performance comparable to dermatologists in this example. I mentioned that early on we were convinced of the value of deep learning. I'll just try to give you a sense of the magnitude of the differences that we were seeing back in 2014 and 2015. This image on the upper right shows a 0.5 centimeter polyp on a haustral fold. Haustral folds are these normal structures that are in the bowel here. This is the polyp detected by a feature-based system. And we had a database of about 1,200 patients. This was one of the largest data sets at its time with 252 polyps in it. And using deep learning, we achieved a 6% sensitivity improvement from 92 to 98% for large polyps and a 17% improvement for some of the smaller polyps. As I mentioned earlier, it took us a year just to get a 5% improvement. Simply by adding deep learning, we got a 17% improvement on this group. Another group of lesions that we addressed, and this is work from Holger Roth, who's in the audience today, was on lymph node detection. This is the lymph node that I showed earlier in the talk, and in this case we were able to get a 34% improvement, a massive improvement on what had been a very difficult problem. At that point the features had to do with a blob-based Frangifilter-based method. This is an example of deep learning applied to lymph node segmentation in work from Isabella Nogues, a former a student in my group, and what she did was use deep learning to segment the lymph nodes in the chest here and the abdomen. The different colors indicate manual and automated segmentations, and these are some heat maps showing the location of these lymph nodes. As I think most of us understand, it's the availability of data that makes all the difference in developing these systems, and we've tried to help the community, as Bram mentioned, by releasing our data sets along with the annotations. This is the first of 4 data sets that I'll mention today, 3 of which have already been released. The 4th, which I'll mention at the end of the talk, is going to be released in the next couple of weeks. This one is the lymph node CT data set, and you can get it by searching for TCIA CT lymph node. It consists of 176 CT scans along with manual segmentations and some masks generated by our detector. For some reason, this particular data set hasn't caught on with researchers, and I hope that you will decide to take a look at it and help us solve this very important task. Another area, as I mentioned earlier, is organ segmentation, and one project that we looked at early on, and this again is work from Holger Roth, presented at MICI in 2016, is pancreas segmentation, where the colors on the left show the manual and automated segmentations of the pancreas. I show this particular task because the pancreas is a very difficult structure to segment. It's a very soft structure. It moves around a lot depending on the bowel that's next to it, and even in the same patient can have different configurations depending on how full the bowel is at the moment of the scan. And this work has also been released to the public. You can get to it by searching for TCIA CT pancreas. This consists of 82 scans as well as manual segmentation. This one has had much more interest, and a number of groups have clobbered us in dice coefficients on this and other data sets. So I think this has really helped move this challenging task along. I mentioned that in radiology there aren't too many applications where deep learning and other systems work comparably to that of trained radiologists. This is one such system that does. This is the colon inflammation detector in this CT scan of the pelvis. This is the inflamed bowel. The inflammation is this thick wall here. The white stuff is oral contrast that the patient drank before the scan, and this detector identifies that area of abnormality with very high performance. In a study of 80 patients and 80 controls, we attained nearly 94% sensitivity and 95% specificity. And in general, for a clinical problem, if you can attain greater than 90% sensitivity and specificity, in general, you have a very useful system for clinical purposes. There are, of course, exceptions, many exceptions to that general rule. In MRI, the prostate is a very interesting problem because the prostate is the second leading cause of cancer death in men, at least in the US. And one of the challenges is that prostate MRIs are very difficult to interpret. The images are very heterogeneous. And these images show T2-weighted apparent diffusion coefficient maps and high B-value images of the prostate, where the cancer is this bright spot here, the dark spot here and here. And this is the annotation of this lesion, and it's detected by this deep learning system, although it was missed by an earlier feature-based system that we also had a part of. This is an example of prostate segmentation. This is an example of work from Ruida Cheng, also at NIH, showing the manual and automated segmentations of the prostate and a 3D model generated from these segmentations. Prostate volumes are very useful for normalizing prostate-specific antigen values, and these are used to help guide whether patients need to undergo treatment or not for these lesions. And a number of investigators in this room, and in fact from the Netherlands, have been leading some of the work in this particular area. For segmentation, this particular segmenter achieved nearly 90% dice coefficient and an average surface distance error of about 0.2 centimeters. At that time, one of the best performing segmenters for this particular task. This particular detector is being used in a clinical trial where we hope to show that the computer lesion probability maps can be used to improve cancer detection. This is being done in conjunction with a device that combines ultrasound and MRI images in real time in order to guide the biopsies to potentially cancerous sites. This device has already been shown to lead to greater cancer detection without computer-aided guidance, and we're hopeful that with the computer guidance we'll get even better performance for this task. This is an example of a clinical trial that was published in European Radiology earlier this year. In this case, the cancer is on this side of the prostate, and here it is here, and this shows the sensitivity of radiologists with and without the guidance of the computer system for lesions having different PIRAD scores. These PIRAD scores indicate the likelihood of cancer being present. This particular system performed best for index lesions and also for lower grade lesions in terms of the performance improvement over the interpretation by radiologists alone. So we've heard a lot about different challenges and how they can be helpful at improving the performance of these algorithms, and the prostate is one example where this has been I think critical to the development of these technologies. The Prostate X Challenge was developed in conjunction with SPIE and the American Association of Physicists in Medicine, and had two parts, a malignancy detection part and a Gleason group prediction part. The Gleason group is the pathologic score that's very important for determining treatment options. There were dozens of competitors, and the winners used deep learning. So I'd like to show you another area in which deep learning has played an important role, and that is in bone disease. This is an example of spine metastasis computer-aided detection in a study that was on the cover of Radiology a number of years ago, where the cancers are these white spots in the spine. This is an example of prostate cancer metastases to the spine. And here the system had a 13% improvement in sensitivity. I mentioned that coordinate systems are very useful in radiology, and I think this is something that's very important in localizing disease, because most treatments are based upon knowing the precise location of an abnormality. And in a series of deep learning studies, what we've done is develop detectors that, given an image, can tell you exactly where in the body a particular finding is located. And in this preliminary work, also from Dr. Roth, we looked at 1,700 patients and over 4,000 images, and we're able to classify images into different body regions, for example, neck, chest, and lower extremities. We had a little bit of trouble in the abdomen and pelvis for reasons relating to training set issues. In more recent work shown at IEEE ISBI by Ke Yan and colleagues, we developed something called a body part regressor, in which the different parts of the body are labeled numerically from a negative value at the top of the body to a positive value in the pelvis, so that there's a continuous representation of the location along the z-coordinate, and this is a feature that can then be used advantageously in multiple downstream processing. For whole body calcium scoring, Zhaimin Liu in my group has developed this abdominal and pelvic calcium scoring detector. This work was presented for the first time back in 2017 at ISBE. These are the plaques here, these white structures. These are calcific deposits that occur in the wall of the aorta and the iliac vessels. This detector focuses on the major blood vessels in the abdomen and pelvis, and this technique uses holistically nested networks or holistic edge detection research that came out of University of California, San Diego to detect the plaques. And we're working on a project in conjunction with a collaborator at the University of Wisconsin, looking at very large data sets on the order of 10,000 patients and matching the amount of atherosclerosis with different clinical factors. Okay, I'd now like to talk about some other applications. Here's an example in the chest where we're looking at interstitial lung disease. This is work from Ming-Chen Gao, formerly at NIH and a member of Dan Melora's group, where these were patients with interstitial lung disease, and the disease is a very heterogeneous abnormality in the lungs, and the annotations only covered small parts of all the voxels that were adversely affected on these CT scans. And she developed a label propagator which was able to extend these labels to all the voxels in the data set. This used a combination of deep learning and a fully connected conditional random field. These are examples of some of this disease. You can see the abnormalities in these different colors, where the original labels by the human annotator are shown in yellow in this example, and then the propagated labels are shown on this row, and they match well with the verified labels. The different colors represent different types of disease, like fibrosis and ground glass opacities and emphysema. In segmentation of the lung, this has been a long-standing challenge, particularly because of the availability of large data sets. We heard earlier this morning about the LIDC and NLST data sets, which are available. These examples show an improved lung segmenter, which works well in the presence of lung disease. This particular competing example performed less well in the presence of lung disease. In MRI, there's great interest in quantitation of soft tissue abnormalities. This is an example of muscle segmentation and assessment for fatty replacement of muscle in patients with muscular dystrophy. In this patient, the muscles of the backside of the thigh are entirely replaced by this fat that appears white on the image, but this detector developed by Jack Yao, formerly at NIH, is able to find a thin band of connective tissue that surrounds the muscle component, hence identifying where the muscle should have been, and then can quantitate how much has been destroyed. And this shows a 5-layer system that he designed that identifies this connective tissue layer. This is more recent work shown at the Roentgen Ray meeting. The Roentgen Ray meeting is a clinical meeting held in the US, and this work from Joe Burns, a collaborator at University of California, Irvine, shows segmentation of different muscle structures, and we envision this as being useful in patients prior to chemotherapy and surgery for whom low muscle mass is a risk factor and predictor of poor patient outcome. And we're getting DICE coefficients now in the mid-90 percentile as shown in the table at the bottom. Large population opportunistic screening is something that I've felt strongly is going to be very important. I believe many of these systems need to be operating in the background and finding abnormalities on the scans, on all scans, not just particular scans. This is an example of a large-scale predictor of visceral fat components in patients. This is the same patient in 2007 and 2017 who went from having a lot of visceral fat, identified in blue here, to less visceral fat. And this is a chart comparing the annual change in fat in the subcutaneous and visceral components in a study with thousands of patients. Here I show an example of work from Ling Zhan, who is formerly of our group, showing tumor growth prediction. In this example, the tumor volume can be predicted at arbitrary points in time in the future by combining information from both multi-phase CT, deep learning, machine learning techniques, and in some cases, calculations of self-volume fractions from PET scans. Okay, so in the remaining moments of my presentation, I'd like to talk about data mining reports and images. And the general theme here is that we're using natural language processing on the reports in combination with the images, passing them through a deep learning system and then providing captions for the images. And our first trip down this path was led by Hu-Chung Shin, who looked at 216,000 key images from CT and MRI scans and got a recall at k=1 of 56%. Just to put this in the context, this is a metric of accuracy that is useful in the computer vision community, but much less useful in the clinical domain. And I'll talk a little bit more about sensitivity and specificity on some of the later projects. What this work did was it could do some straightforward things like classify images into different categories like brain, breast, spine, and extremity images, but of greater interest, it could classify lesions as having metastases or no metastases simply on the basis of learning from these key images. And what this could do is something like sort of a search engine approach. If you feed in the image, this system would output 3 descriptive words as a caption for this image. For example, this image, which is an MRI of the abdomen showing a cancer in the kidney, the computer output diameter, mass, and kidney, which is a correct label because the sentence describing this image was that there was a 1.6 centimeter diameter mass in the kidney. So in this case, of course, this word's trivial, but this was an accurate label for this image. Further work by Xiaosong Wang in my group led to more accurate captioning. Here's an example of top 10 accurate labels for these MRI and CT images showing metastatic disease to the liver on both of these scans. In CVPR in 2016, we talked about data mining reports and images on chest radiographs, combining CNNs with RNNs in order to generate more accurate labels. And in that work, looking at chest radiographs, we were able to feed in images like these normal chest radiographs and get correct diagnoses of normal. And we could also detect things like tortuous aortas, degenerative changes in the spine, and in some cases, masses in the lung in that early work from 2016. In 2017 at CVPR, we showed a more sophisticated model that included saliency maps that showed where the abnormalities were in the images. For example, atelectasis or compressed lung, pleural effusions, and masses. And that led us to develop the chest X-ray 8 data set, shown. It's called chest X-ray 8 because there are 8 different categories of disease. At that time, we were able to get accuracies that ranged widely depending on the abnormality, from a low of only 16% for nodules to a high of 99% for enlarged heart or cardiomegaly, at very low false positive rates approaching only 1 in 10 or 1 in 20. This is the third data set that I'll mention that we released to the public. You can get this by searching for chest X-ray 8 data set. It consists of 112,000 chest radiographs from over 30,000 unique patients, includes metadata for all the images and bounding boxes for 1,000 of the images. And we're presently working on preparing the radiology reports for general release, hopefully in the coming months. In 2018, Xiaoseng Wang showed TINET, a text image embedding network. This was at CVPR just a couple of weeks ago, in which the computer system didn't just provide captions, but it actually wrote a radiology report, a preliminary radiology report. And sometimes these radiology reports were true. Although most of the time, while grammatically correct, they amounted to little more than gibberish. But these are examples of some of the correct and incorrect findings of compressed lung, fluid findings, no findings, masses, and so forth. This particular paper can be found on the CVPR website and on arXiv if you're interested in learning more. And the final data set I'll talk about is the deep lesion data set. This was discussed in some detail at CVPR a couple of weeks ago. This data set includes subvolumes of CT scans showing a wide variety of lesions in different parts of the body. This map shows the different clusters of images in this data set. There are bone images, abdominal images, mediastinum images. The mediastinum is in the chest. There are liver, lung, kidney, soft tissue, and pelvic lesions. And for each of these lesions, there's a bounding box is provided. And in addition, the measured size of the lesion. There are 32,000 lesions on 32,000 CT slices. These come from over 10,000 CT scans and represent over 4,000 unique patients. The measurements come from what are called RECIST measurements. These are bidimensional measurements like this one on this adrenal mass here. Most of the lesions, well, actually all of them in the data set come from CT, although in the future we may release other types of lesions. Over half, just about half of them are from RECIST measurements. Most of the lesions are in the 1 to 3 centimeter size range, and they tend to be from recent technology CT scanners from the last 3 years. The type of things that you can do with this data set or have sophisticated queries. For example, if these images are query images of a lymph node in the armpit or in the mediastinum or a lung lesion, you can feed in this query image, and in this retrieval task, you can pull out lesions in the identical spot on other images. So not just telling you what type of lesion, but precisely where, to exquisite detail, where the lesion is located. Here are some other examples in the liver, the kidney, and in the soft tissues. And one of the neat things you can do with this data set is collect subgroups of these images for use in downstream studies. This is an example of a downstream study on pancreatic cancers. And here are the cancers here. Some of them are a little hard to see. And this was part of a project where we wanted to look at this particular type of lesion. And what we did was we fed in, using the body part regressor, where in the image we were interested in lesions, and then extracted the lesions from the deep lesion data set. And finally, what we've attempted to do is develop a universal lesion detector. So this is a detector that gets closer to my goal of fully automated abdominal and pelvic CT image interpretation. This particular detector is able to find lesions in all these different organs using the deep lesion data set for training. And so, for example, we can, actually, it's not just the abdomen and pelvis, this is in the neck. Here, these are different lesions, lung lesions, mediastinum, liver, retroperitoneum, that's part of the abdomen. The performance of this detector is in the roughly 80 percentile for a number of these different locations, a little lower in bone and kidney. These are areas that we're working on improving, and it typically does better than an RNN-based baseline system. And finally, this is an auto-resist system that Yu Bao Tang in my group developed, and we'll be presenting at MICHI in September in Spain. This particular system measures lesions automatically in 2D, part of an oncology package that is very important in cancer patient diagnosis and treatment. These images show the original lesion in different parts of the body, the segmentation of the lesion, the reorientation of the lesion into a common framework, and then these 4 images here show the bidimensional measurements, which are then produced here and turn out to be comparable to the mean values of the measurements made by multiple radiologists. So the idea is to standardize these measurements. It may seem kind of silly to you that we'd be focusing on bidimensional measurements rather than volumetric measures, but these are what is supported in the clinic. So what are my expectations for the future of these methods? I think new discoveries are going to continue and will benefit individual patients and populations of patients, enabling us to do epidemiologic studies. And the way I envision this working is the routine integration of radiology images with other clinical data. So right now, most radiology images are overwhelmingly large collections of voxels that are difficult to integrate with other types of data like genomic information and lab values and clinical findings. But I believe that sort of problem is going to go by the wayside in the future if it hasn't done to a great extent already. I think these techniques will be used for triage and critical result monitoring. We're already beginning to see some commercial approved systems, FDA approved systems that can do triage. By triage, I mean moving images that have more critical findings to the top of the stack so that they're interpreted earlier, so that it takes less time to identify patients with critical abnormalities. There are many global health applications for these technologies. There aren't that many trained radiologists and other trained physicians in many parts of the world, and I envision many of these techniques helping them. And you may be aware of some groups that are working, for example, at detecting tuberculosis on chest x-rays in less medically advanced communities. And finally, I think we're going to see more automation and quantitation in radiology. Believe it or not, most of these images are read entirely manually, and there's little in the way of quantitation today. And there will be changes in the practice of radiology, but I should say change has been the norm over the course of my career. So I don't shy away from change. I see that as actually the way things always are in my field. If you'd like to learn more about some of the things that I discussed, I encourage you to take a look at a review article I published in AJR and an editorial that I co-authored with Hayek Greenspan and Bram van Ginneken, and a recent editorial in abdominal radiology. The work that I showed is the product of many collaborators, both at NIH, at universities, and elsewhere, and funding from many different organizations, both at NIH and others, and as well many different training programs. I invite you to take a look at my website if you'd like to learn more about what we've done. We have over a dozen of our papers are on archive if you're interested in that. There are links to the data sets that I mentioned on my website, and I am happy to answer your questions. Thank you very much. Yes.
Any questions?
All the way
in the back,
yes.
Milan.
Thank you for a great talk and a very nice overview. You mentioned that you expect changes in the way of radiologists work in the future. Is that in direction that you mentioned that radiology would be integrated with the other data, and then the things will be moved towards clinicians, or you have some other directions? So could you elaborate a bit on that?
I think the ways in which these technologies are going to be integrated into clinical practice will vary quite a bit depending on the nature of the healthcare model, both locally and internationally. So that predicting the future, I've learned, is not my forte. So I think that's about as far as I can go. I think the different things that I mentioned will be used in different contexts more and more, particularly as the accuracy improves. It's very easy in clinical medicine to both buy into the hype of deep learning, but also be highly critical of the results to date. As I mentioned, many of the techniques still don't perform as well as clinical radiologists or other types of physicians. And once that performance starts either improving clinical outcomes, which is a very difficult thing to show, or improving over routine tasks, either in terms of improving efficiency, it'll be very hard to get clinicians to adopt them. Clinicians are very focused on things that work in the present, and they want things to have high performance to improve patient care and not to slow down the clinical task, because the clinical environment is a very dynamic, quick-moving environment in which there's not a lot of tolerance for time-consuming and burdensome additional technologies. So these are some of the factors that are important in taking a technology from the research lab to the bedside.
Just a very quick question, probably as a follow-up. I really liked the result that you were showing, even though it was not working very well, of the image captioning. So that idea of creating radiological reports. And obviously it's going to be extremely complicated to deploy these in clinically as it is. And even if that technology evolves, it's going to be complicated anyway due to the associated risks. Do you see a translational pathway from the technology as it stands? Which parts of the clinical workflow, even managerial workflow, anything within the clinical process that could be changed slowly so that in 10 years' time, we can actually have this technology replacing a certain percentage of radiological reads? What do you see that translational pathway be?
Right. So I think the low-hanging fruit would be to start adding automated quantitation to the reports. For example, in pulmonary medicine, for example, a pulmonary function test, there's a whole litany of numbers in a pulmonary function test report. An echocardiogram, the cardiologist put in many numbers of all kinds of measurements of different parts of the heart. In radiology, we might make those RECIST measurements of lesions, but we don't routinely provide measurements. There are all kinds of things that could be put into the report. Organ volumes like liver, spleen, kidneys, body composition measurements, fat, muscle, bone mineral density, atherosclerotic plaque burden in different parts of the body and different vascular distributions. I'm sure if I thought about it, I could come up with more examples, but these are the kind of things that could start becoming just filtering into the clinical workflow that would require little in the way of regulatory concerns, simply because these capabilities don't exist, and there could be caveats about what the accuracy range is in general for these technologies. For example, I would say for liver segmentation, you can generally have dice coefficients in the mid-90s. We've seen many papers that have achieved that sort of performance. So You could even include, along with the measurements, a little thumbnail picture of what the segmentation looked like so that major errors in the segmentation could be quickly detected. You know, that sort of low-hanging fruit would be, I think, the first step. And then as that began to be more accepted, you'd start seeing more quantitation, more automation. I don't even want to go into what the economic model is for those sorts of things, but I really do believe that that would be a workable path from a regulatory point of view and from a technological point of view.
Anybody else? Maybe a quick question, Ron. You mentioned data sets of 100 million cases. That sounds interesting. How do we get there?
Right. Clearly, it's a multi-institutional problem, and I have talked with people over the last couple of years who are starting to think about this challenge and are starting to form early consortia in which the images could be collected. That has to be, I think that would be one successful approach. So I would encourage groups around the world to start thinking about how to do that and start meeting and collaborating on setting up a structure on how to develop those sorts of data sets. I know that impediments immediately come to mind, like patient privacy and confidentiality. I believe that those issues are possible to overcome in a way that's acceptable to patients. And I think one approach that I've heard about, I haven't done it myself, is deploying the training and testing modules at the individual sites so that the data doesn't actually leave the site. So these sorts of distributed models might be one way to overcome the privacy and other patient rights issues. So I believe that's where we need to go for these technologies to move forward. There was a question in the back.
Yes, it sort of follows up on what you already mentioned, that it would be nice to have the feedback loop that indeed the clinicians working with these new technologies can feed it back into the system, and the system keeps learning and learning indeed. So we already mentioned it, but maybe can you elaborate how you see that interaction between the trained physicians and these technologies?
Right, so there's a concept you're probably familiar with called active learning, where systems would improve over time. There are some regulatory issues about that because, as we know, the quality of the annotations or labels are critical to determining the performance of the system. And one of the factors that regulatory bodies look at very closely is the quality of the annotations or labels. If the labels were coming from the sites at which the systems were deployed, there would have to be some kind of quality control over those labels. So I can see active learning happening in some form, although I'd like to see more thought go into how to set up such a model so that the label quality is maintained.
Okay, thanks.
Final question from Max.
So I wonder whether radiologists, so if there's something that radiologists might not trust about the prediction of a machine learning algorithm, maybe it could be something like, is it robust enough if you change the scanner or something like that? So is there something in their mind that maybe makes them hesitate to use this technology?
Right. Why do clinicians hesitate to use the technology? Well, clinicians work in a very dynamic, fast-moving environment, and they need good evidence that there will be better patient outcomes from whatever the technology is. So if the technology looks in the lab to be high performing, but when it moves to the clinic, it actually makes little difference on patient outcomes. And when I say patient outcomes, that's kind of a broad overview term of somehow the treatment leads to shorter disease course or more cures or longer survival. You know, there's lots of different patient outcome measures. Those are the things that are important. So for example, for prostate MRI, these images are very hard to read, and sometimes these computer systems can lead to more prostate cancer detection, but then the question becomes, how are the outcomes improved? Do the patients live longer, or do they just have a similar rate of metastases and a similar long-term survival? These are very complicated questions, and when physicians have these sorts of questions in the back of their mind, it provides a justification for not adopting the new technology. So the question is how to overcome these very rational criticisms. One of the best ways is to show improved outcomes. Another way is for the patient communities and other communities that are stakeholders in patient care to come forward and say, you know, we want this. Because you have to keep in mind that there are many, many players in the healthcare system. The patient's the most important. Physicians are only one of those players, and so there are many opportunities for finding pathways to success in transitioning from the bench to the bedside for these types of problems. Thank you.
Okay, let's thank Ron again for a wonderful lecture.